Good morning, everyone. It's my pleasure to be here to welcome all of you. As Angela mentioned, we were just astounded by the a number of people who were interested in joining us this morning. We're not surprised by it, but we're certainly pleased to see so many people here today. You may know that the MS Society of Canada has been serving persons affected by MS for 68 years now. And we do that together with our dedicated volunteers, our event participants, our sponsors, and our generous donors. And together, we have been able to make some significant progress in our mission to find a cure for MS and to enable people affected by MS today to enhance their quality of life. You may also know that we've made tremendous progress over the years in MS research. And we're very fortunate today to have some renowned MS researchers with us. Canada is a leader in MS researchers. The work that we're doing here is being watched by countries around the world. And we're working in partnership with some of those countries because together, when we pool our resources, we have a better chance of being able to achieve our common goals. So we're very honored to have Dr. Freedman here today, as well as Dr. Bruno and Dr. Robinson, to share with us some more details of the very exciting work that they do. We thank you again. Your commitment makes a big difference in our work. We appreciate that, as Angela said, many of you are affected by MS, either personally or as caregivers, and there are many, many issues and questions that you face. So thank you for your understanding and patience in remembering that we do want to focus on the information that's being shared by our speakers. Certainly, they are going to be very happy to answer the questions you have related to the information they share. And at the MS Society, we will continue to do everything we can to ensure that we are sharing updates with you about many of the new developments that are happening in research and about many of the tremendous programs and services that we are able to offer to persons affected by MS. I'd also like to take a moment before we get started to acknowledge our sponsors for today. Without these sponsors, this event would not be possible. So I'd like to take a minute to thank our lead sponsor, Novartis, as well as our contributing sponsors, EMD Serono and Biogen. And Roche, sorry. And these, again, this type of sponsorship enables us to bring people together, to have these tremendous speakers. We really would not be able to do it without them, so we truly do thank them for their support. So at this point, I'd like to turn the mic back over to Angela. She will serve as our MC today, and she will be able to properly introduce our first and keynote speaker of the day, Dr. Mark Freedman.
Thank you, Lisa. Thank you so very much. I just noted that there are some people who are seatless. So we have 2 seats up at the front right here. So if 2 individuals want to work their way up to the front here, we still have 1 more seat over here. We've got 2 seats, 3 or 2 seats over here. Another one. We got lots of seats. It's just a matter of you working your way up. Okay, thank you. I think I did say about lunch, and I gave you all those instructions. I just want to make sure you know that it will start at 12:15, 1:30, and that the hall will be open. So here we go. I am thrilled to introduce Dr. Mark Freedman today. Dr. Freedman is currently Professor of Medicine in the field of neurology at the University of Ottawa, as well as Director of the MS Research Unit at the Ottawa Hospital General Campus and a Senior Scientist at the Ottawa Hospital Research Institute. Dr. Freedman is also the lead investigator in the Canadian bone marrow transplant study in MS and co-chair of the International Mesenchymal, I'm never going to say that, Stem Cell Transplantation Study Group. And I thank him for being here today from Ottawa.
Thank you very much for this kind invitation to actually come home. This is where I'm from, in Toronto. Grew up not too far from here. Was mesmerized by all the activity that has changed over the years in Toronto. I'd like to say I miss it. I think I liked it back when I could actually see a few trees. Just driving in from the airport, I could only shake my head. But we're out at the farm in Ottawa. It's a nice little town. At least when I moved there, it was seeming like a hick town after living in Toronto and Montreal. But it's also growing like the rest of Canada. And with the growth, of course, comes some other problems. And we're starting to see a little bit of big city problems in Ottawa that we didn't see years ago. MS is also growing, and the research has really developed. And I was asked to bring you up to date with some of the current or imminent therapies that we have, and of course discuss our projects with stem cells. So I hope I don't bore you too much in the next almost hour she's given me to speak with you, and then we'll have some questions afterwards. So with that, if we can have the slides. Good. All right, some disclosures here. All right, so my objectives for the day here are to review some of these new therapies. I'll show you some of the latest data. One of the 3 drugs that I'm going to tell you about is currently licensed, like literally just, and the other 2 are going to be hopefuls. Things take a little bit longer in Canada. We have a certain pace with the government. I don't have to tell you. And things take time. So it may be within the next year or so we should see the other products. I'll tell you a little general discussion about stem cells in general so that you have an idea of what these are. And there's so much confusion out there. And then, of course, I'll tell you about the results of our trials. So this is a little map of what's going on with MS. The therapies that have made it to market are in the center of this target, and around the target tells you a little bit about the various types of therapies that are being developed, but you'll notice little spots everywhere, and that is the ones on the outside of the target are the ones that are currently being investigated. At our site in Ottawa, we probably have, I'm going to guess, around 25 ongoing treatment trials right now. At some points it's 30, and we probably have another 5 or 6 that are waiting to be approved by our ethics board to continue. So there's no shortage of interest in developing new therapies for the purposes of treating the disease, slowing it down, or repairing it. And all of those are being looked at now. The landscape has changed dramatically from medications that we've had to just simply reduce relapses, and now we're into some of the oranges is now all progressive MS trials that are ongoing. These are for a large group of people who've missed that opportunity to be treated for medications to reduce relapses. What about them? The focus is now really all about them. In fact, the world has joined in what is referred to as the Progressive MS Alliance, and we're pooling resources and research scientists to come up with answers to address all the progressive forms of MS and see if we can't slow it down, treat it, reverse it, maybe even repair it. I mean, that is what's going on today. So we've had some failures. Those are the ones that are shown here. There was some thought that some of these drugs would do something, but the trials have failed to show benefit. But we learn every time from even failed trials that maybe coming at progression from one angle is not the way to go, and then we know which way we should follow afterwards, and that's important. So this is one of the drugs that has just finished its trials and literally got approved by Health Canada at the end of the summer. This drug is one of the first to show and prove that it can slow progression in a primary progressive group. But unfortunately, Health Canada has not approved it for that. So we are still awaiting approval for progressive MS, but it was also shown to be a very potent therapy at reducing the relapsing form of MS. And I'll just quickly show you the data that supports that. This is an antibody. It's called a monoclonal antibody. Antibodies look like the Y, which is what's shown here. And at the little ends of the Y are the really specific areas of the antibody that will bind up a receptor on your B cells. And because of the bottom part of the Y, that is married to the human system. The little ends of the Y are actually from mice. So, and we have to do that because normally we don't make antibodies against ourselves. We have to go into another species to do it. So there's a little mouse in there, not much, but right at the ends. And then the rest of it is human. So this is what's called a humanized antibody. And we've gotten really much better at these over the last 25 to 30 years since the technology was invented, and actually the person who invented it won the Nobel Prize for that. So monoclonal antibodies can be developed to very specific targets. So these are the lasers that we can use medicinally, and they're in every facet of medicine today. So this is in MS, but those of you have probably heard similar drugs in other autoimmune conditions, rheumatoid arthritis, lupus, psoriasis. You see the commercials on televisions for all these drugs. They all end up in MAB. Anything that ends in a MAB is a monoclonal antibody. And there's in cancer, right? Everything has them, because as soon as you identify something on the target, you can hit that target very directly using your body's own system, which actually does that for a living. It is targeted therapy. So that's how sophisticated some of these can be. But they can also be very dramatically effective to the point where they take everything out. And so the concern always with a monoclonal antibody is that you get the dose just about right so that it doesn't eliminate everything, because if we're talking in the case of this particular monoclonal antibody, the target being an important cell of the immune system, the B cell, you don't want them all gone, because at some point you're going to need one to generate the normal antibody responses that we dwell on for things like immunity to the flu. You're going to get a flu vaccine probably in the next couple of months as the campaign is opening up in Canada. And ability to generate antibodies requires your B cell. But in the case of MS, it was noted that B cells are very important drivers of T cells. And what we see as the end result in most immune reactions, doesn't matter what we're talking about in the body, whether it's a bad immune reaction that leads to disease, like in multiple sclerosis, or a good immune reaction, like walling off a virus and getting rid of it, it's typically the T cells that are really the troops that are doing this. And I think that's a good reminder here that it would be nice for everyone else if you turned your cell phones to silent, which I did with mine before I stood up here. Okay. So a few trials were set up with Ocrelizumab. There was a predecessor to Ocrelizumab called rituximab, very similar antibody. It's been around for probably the last 20 years. It's been used a lot in rheumatoid arthritis, but it's a bit of a dirtier antibody in that it had just a little more mouse in it than the current one, and perhaps was less effective. It's been used regularly for treatment of B-cell disorders, things that you probably haven't heard of, but the commonest B-cell disorder is actually lymphoma, which is a cancer of the blood. So that was a routine treatment for cancer of the blood. But it was starting to be used a lot more south of the border for routine treatment for MS in certain states where they are all reimbursing for it. And it's been used sort of haphazardly in Canada up until now. So now that they got this nice clean molecule called the Ocrelizumab, they set about doing 2 identical trials. Today you have to do 2 trials to prove that things are working. And they were pretty convinced of the efficacy. So rather than doing a placebo-controlled study, which is almost impossible to do in countries like ours today, because you can't ask someone with active disease to go on nothing for 2 years. It's just unethical when you've got all sorts of other possibilities. They went up against what was considered one of the best first-line medicines, which is high-dose interferon. And they said, let's see if we can beat it. So 2-year trial, 1 arm using periodic dosing with Ocrelizumab. It's dosed every 6 months as an intravenous versus the 3 times weekly injection, self-injection of interferon. And so this is just the numbers of the 2 studies, OPERA-1 and OPERA-2. You can see, those of you who like reading numbers, that the baseline characteristics of the populations were your typical relapsing remitting patients, and the numbers are almost identical between the 2 studies, and these were all done at different sites around the world. It's a very international study. And the primary endpoint of this is, in fact, relapse rate reduction. So on the left for each of the 2 studies is the interferon group. The relapse rates are very low in these trials. So 0.3 attacks per year. Yeah, I know it's very hard to understand. How many of you have had 0.3 of an attack? Okay, I mean, really. So it's like 1 attack every 3 or 4 years is what it boils out to, which 20 years ago, anybody here would have taken. In fact, even on placebos today in trials, because we're getting to patients so early, the attack rates are very low. If you're lucky, you get 0.4 or 0.5 in a placebo group today because the diagnosis is made even earlier. And the earlier you make the diagnosis and start therapy, the better the results. Nevertheless, you can see that on the Ocrelizumab, there was substantially fewer attacks, almost 50% reduction. And almost identical numbers were obtained in both clinical studies. So very convincing in the first and similarly convincing in the second. So that's one thing. We measure relapse rate, but everybody knows that having a few attacks is not what you're really worried about. It's what they accumulate to and what ends up with disease progression. That is the key, and we're all trying to prevent that. That is the hope of every study. And so, in fact, you can see here that it takes time to even develop progression on the interferon. We've known that. Why do you think interferon has been a treatment for many patients for so many years? It's because it works. And you can see it takes almost a year for the 2 curves to start diverging here. But the group that took the interferon is the top line. So more of those patients ended up with meeting the definitions that we use of EDSS progression. Everybody know what EDSS is? You should, because it's what your doctor should be applying every time they do their neurological exam. They translate the findings into a scale, which is called the EDSS. And it's used not only for research purposes, But many of you who are on therapy and rely on our famous Trillium plan to pay for things, Trillium demands that your neurologist sends the EDSS with your request for a renewal of their medication. So if they're not doing the EDSS, or they're probably doing it, they're just not telling you what it is. And the scale measures progression, and you can see here that there were fewer progressions in the Ocrelizumab arm compared to the interferon, whether you defined it as a sustained progression for 3 months or 6 months. And the reason why we make that designation is because if you've had an attack and you got a little bit worse and then you got better, that's not really a progression. So the longer you wait to see that it didn't get better, the stronger the influence and the credibility of the change that we're seeing here. So 3 or 6 months made no difference. And then if we look at the other, I call them substantive evidence, the MRI is not your disease, and a lot of people believe that. The MRI cartel is probably listening to me right now. I don't make money on MRIs, but there are parts of the world where they live on MRI. And so the more technology you throw, the more money that is being made. But the information that is gleaned from the MRI helps us to make decisions, but they don't make the decision. We've never seen a medication that has worked for the inflammatory forms of MS that has not really affected the MRI. But so often we see changes on the MRI and patients don't perceive of any change whatsoever. And there are other occasions where we see obvious change in patients and the MRI hasn't changed at all. Depends where you look and when you look. However, it is what I call it is a substantial because it's objective. Patient doesn't have to tell you anything. The doctor doesn't have to interpret everything. It's a picture in time, and it keeps us all in balance if we make a claim that something's effective. If I showed you this data and I didn't show you the MRI getting substantially better, you'd go, wait a minute, why did it cut down on relapses and slow progression, but how come the MRI isn't any better? It's our check, okay? And you can see here that the MRI always beats the clinical because it's a more sensitive index. And so the differences here are even greater than you saw clinically. A nearly 90% plus suppression of MRI activity, whether you measure it by the number of new enhancing lesions or you look at it by the number of white spots that has changed over time. That's what this T2 means, so the 70 to 80% reduction. So it substantiates, gives some credibility to the changes in relapse rate and progression. We also measure volume changes, and I will show you a bit of this later, I think with our stem cell work. So everyone's losing brain on a daily basis, unfortunately. It's called aging. And really you can't tell, but this computer software today is incredible. And if you do very sophisticated scans as are being done in these trials, you have the ability from the computer to measure even a fraction of a percentage change in overall volume over a year. The eye can't see that. If you showed me 2 scans that were 0.1% difference in volume, I would not be able to tell that difference at all, but the computer can do it. It can do it using the sophisticated scan network of a clinical trial. This does not work in real-life practice. You can't go and have 2 scans and ask your doctor, was there any volume change? There's not a chance that they'll be able to see it. And even though we all have the software now at our centers to measure it, the noise in two scans done haphazardly is greater than the amount that's actually changing over the course of a year. Why is that? And that is because in these studies, anybody who's been involved in a clinical, has anybody been here in a clinical study? You know what goes on when you go into that scanner. It takes a lot longer for doing a clinical study scan than it does for your routine MRI. And that is because the first time you go into the scanner, your head and all its components in the brain are registered in three-dimensional space, and the computer saves it as a grid. When you come back for your next scan, you don't just lie there for a second and they just make a quick adjustment. Sometimes they have to reposition you because the scan has to line up all those points in time within 1 millimeter of where it was before. So the positioning can take 5 or 10 minutes. And time is money today on machines, right? So they're not going to do that on a routine scan, but we do it for the clinical trials because otherwise the scan is rejected and then you have to bring the patient back and rescan them. So the scans to scan differences are within less than a millimeter. And because you can collect scans over time like that, you can do things like measure brain volume. And here, oh, our slides disappeared. Here you can see the changes on the left on the y-axis here are within a fraction of % per year. And so you can see the differences in the loss of brain tissue between the interferon arm and the Ocrelizumab arm, suggesting that what we had seen with disease progression is also translating into less lost brain tissue in the group. And if you went down to the individual patient, even in this study, you would lose that ability. But it's the group data that generates that. And that was true of the second study as well. So I just showed you both results. Now we're starting to talk about NEDA. And I'm using just this trial as an example to illustrate to you what NEDA is, because you're going to hear all about it. NEDA stands for No Evidence of Disease Activity that we can measure. And of course, we're not measuring everything. So of the things that we're measuring relapses, progression, and MRI. For whatever reason, when we do clinical studies and look at those outcomes, we look at them independently. So if somebody, we've done a study, and somebody has had fewer relapses, we don't know whether that person who's had fewer relapses had progression or not, or had any MRI activity or not. We only look at the group that had fewer relapses. And then we look at the group again, and we look at those that didn't progress. And the same thing is true for the MRI. Now, in real life, we look at everything, right? As the clinician, we're trying to put all these things together. So if somebody had no relapses but had 3 points on the EDSS progression, I would be very concerned about that patient. But it's very possible that the same person in the study here that had no relapses actually progressed. So on the one hand, they're good, but then they're bad. Or what if the same person who had no relapse had 10 new lesions on their brain? So you have to somehow put this data together, but nobody's ever done it because that's not the way the trials are conducted. So we started to look at NEDA as, well, it only makes sense that you count somebody as good if they didn't have a relapse, and they didn't have a progression, and they didn't have any MRI activity. Then they'd be really good. No one's going to question that, except if you do a routine study today, believe it or not, even on placebo, the NEDA rate is probably somewhere between 10 and 20%. That's because most people, fortunately, early in their disease, don't have any evidence of disease activity. The disease pops up, and then it goes away for a while, and then it pops up again whenever, and then it might go away for a while. And then if you add therapy on top of that, that a while lasts longer and longer, right? So NEDA is now looking at a difference, and the only reason it's useful here is because we're talking about 2 different treatments here. So in the first study, there was a 64% increase in the number of patients who were NEDA on the Ocrelizumab arm compared to the interferon arm. And in the second study, it was almost a little bit more, but so there are more patients who are free of any measurable disease activity, which is interesting, except you don't know what the natural history is for these two groups, but you do have a comparison between the two arms. That gives you something convincing to look at. All right, well, that's the good side, right? So what's the downside, right? There's never a free lunch. So here's a way of breaking down this NEDA. So you could look at the NEDA, Ocrelizumab versus interferon. You can see the differences in terms of relapses, or you can see the differences. Those are the clinical, so that's relapse and progression, and on the bottom, the enhancing lesions and the T2 lesions for an overall rate of 48 versus 28, is it? An overall increase of 76%. So pretty compelling that this drug is superior to subcutaneous interferon in a naive population. That's important to know. These are all patients who've never received therapy before. And so now what? What are about the adverse events? Now keep in mind, this is but a 2-year window in the life of a patient. And we're talking about therapy that for many people extends beyond 2 years, right? So if these are the kinds of adverse events that are collected in 2 years, they are really a hint at perhaps what might go on later. And later even supposing continued administration of the same drug, right? So it's only a 2-year window. And then on top of that, this is a cherry-picked group of patients. What do I mean by that? All right. Let's have a raise of hands from people here who have wanted to get into a clinical trial but were refused. Okay? Not uncommon. Why? Because you didn't meet inclusion-exclusion criteria. So why do we have these things? The inclusion criteria are usually set up so that we get the most out of every study. That we're trying to bring in patients. If we're looking at if we're looking at relapse rate, we need to know that there's a good chance they're going to have a relapse. I mean, that's just the way it's done. So you try to pick a high-risk group who are likely to have the event in question so we know if we're winning or not. So the inclusion criteria are trying to get the most informative patient, not just go a big wide net, because if you bring in too many people who don't do anything, then you've wasted all your money on a study that's not going to be informative. So that's the inclusion part of it. The exclusion part of it is where we run into trouble with these adverse events, and why, when we collect them during a study, they're so different than what might happen after the drug is being released. The exclusion criteria, somewhat are theoretical, and others are actually mandated by the regulatory. For instance, we can't treat anybody under the age of 18. There's lots of people under the age of 18 who get MS, but by the Declaration of Helsinki, we cannot do clinical trials unless they're specifically in a pediatric group, so that doesn't count. And usually there's an upper limit as well, 65 or 70, depending on the study. You can't treat. Some of them are cut off even earlier, 50, 55. So age. There's also confounders. So you're not allowed to have anything else wrong with you. Well, you know, MS is an exclusive disease. You're allowed to have other problems. And so often we get patients who are referred back to us from our family doctor with back pain, claiming that it was their MS. I said, you know, they're allowed to have back pain. What would you think of if they didn't have MS? Right, so it's the confounders here that exclude anybody who might muddy the waters of a clinical trial. So if you're not sure if diabetics may or may not be ill-affected by the drug, you exclude them. And so there were a lot of exclusions for clinical studies. So that's why I say that these were cherry-picked patients. You're picking the good ones, have MS, have activity, and don't have anything else wrong with them. Now, when you release a drug into the general public, it's up to the authorities to say who should and should not get the medicine. But they base it on these types of data. So on this type of data, a cherry-picked population here might do very well. But when you start to give it in the community, Who knows what's going to happen? And so much depends on what we're going to collect once the drug is out there. So if you've been looking for Ocrelizumab and your doctor has some hesitations about it, I'm just telling you where that hesitation comes from, whether it's this drug or any new drug when it's first released, only on the basis of clinical trial data. We are nervous, especially if you have something else. What if you had hypertension and it wasn't controlled? Maybe there's a problem there, we don't know. But here are the adverse events. We know what goes on with interferon. When interferon first came out, we had the same discussion. Nobody wanted to take it. It was very worrisome. You had to inject. It was terrible. Now we have it. It's for 30 years. Nobody's worried about interferon anymore. We know that it is non-toxic. People could take it for 30 plus years, and we don't see any new problems. That's hindsight. That's wonderful, but we don't have this kind of information for this particular therapy. So there were some issues, slightly more on the Ocrelizumab side. And I think one of the big issues that has come up, that has just raised a few eyebrows, are the number of malignancies that were picked up, more so in the Ocrelizumab arm than the interferon arm. And when I'm going to come to a moment, the primary progressive story, I'm going to show you again this issue about the malignancy that popped up, and in particular, breast cancer. So it happens to be that more women get MS than men. That's just the way autoimmune disease works, but there's always a concern when breast cancers are picked up in only a 2-year study where there's mostly young people in this study. So is there something about the B-cell suppression that may let malignancies out? The numbers are way too small here in a clinical study like this to make that conclusion. This could have happened by chance alone, no question. You take a large group of people and follow them and look for things, and guess what? You look for things, you find them, right? You know what the definition of a normal person is, don't you? And who's ever heard this joke, don't shout it out, okay? Because I use it all the time. What's the definition of a normal person? Someone who hasn't had enough tests done. Okay? True, huh? Okay. All right, so I'm going to tell you about the primary progressive group of studies. Now, this one, unlike the OPERA studies, because there is no treatment for primary progressive, it is ethical. I know none of the people who were in this study felt it was ethical, but it's ethical to use a placebo group, to be sure. So one group gets Ocrelizumab. The study went on for well beyond 2 years. The other group got nothing, placebo only. And what we looked at were very similar baseline characteristics, slightly older patients, as one would expect for primary progressive. A little more equal in terms of men and females, male and female, because more men tend to present with the primary progressive form for whatever reason. So there's more equality there. Interestingly, though, about a quarter of the patients, despite the fact that they had this primary progressive form of illness, had enhancing lesions on their baseline scan. And as time went on, actually, about 25% actually experienced a relapse after the definition of primary progressive. So this is making us wonder whether these designations of primary or secondary progression mean anything, because when you look at everything underneath it, it all looks the same. There are people who still have inflammation. There are people who get new lesions that look identical to relapsing disease. If I showed the brain of a primary progressive, a secondary progressive, or a relapsing patient to a pathologist who knows something about MS and asked them to match the brain to the phenotype, they wouldn't have a clue. If I showed the MRI of 3 different types of patients to an experienced MRI radiologist and said, what form is that? Relapsing, secondary, primary? They wouldn't have a clue. All looks the same. The only difference is how the individual presents. And I think what primary progressive patients are doing is they get silent relapses for years. Just never knew they had it. And then one day come in dragging their leg. And then we look and we find. And if you look, about 25% of people still have activity. So once again, the two curves. The placebo group is the gray. So you can see here that the progression in this study is very slow, right? Those two curves are really not separating very much until well into the second year of this particular study. And that's on the bottom here is the numbers are in weeks, right? So do I have a laser here in the middle? I can point it on here. So, you know, 1 year is here and 2 years here. Why does it keep going out here? Because unlike previous studies in primary progressive MS, which made a finite stop at 2 years, it was very clear that not enough events had accumulated to see the differences between the two groups. And so this study was allowed to run as long as was necessary for the statisticians to say, hypothetically, we have enough events now that if there was a difference between the two arms, we should be able to see that difference. And so it was an event-driven study, and as a result, it went almost like 3 or 4 years for some patients until we were able to see enough events. And you can see it was a late phenomena that the curve started to diverge. And all we can say is that the group that took the Ocrelizumab did progress a little slower than the group that got nothing, the difference being a modest 24%. Yeah, not huge. An overall percentage-wise difference between the two groups is not very much, but it's statistically significant, and for the individuals, I'm sure it's meaningful. The problem, we did this study, and the patients who were in this study could have been in either arm here, but look what's happening over time. They're getting worse. And it was a lot of pressure and hand-holding to keep people interested enough to stay in this study. Because despite the fact that they're getting worse, I have to say, well, it's possible that you might be getting worse a little slower because you might be on the drug. It doesn't really get to the heart to people to say, well, that's not really giving me enough oomph to stay in here, but I don't really have another choice, so I might as well hang, right? And some people would leave, you know, because they got discouraged because they were getting worse. But only at the end were we able to detect that the fact that the patients, some patients who were on the drug got worse a little bit slower. So, you know, you're wondering why Health Canada is dragging its heels on approving this for primary progressive MS. I think if they're going to approve it and then ultimately pay for the drug, we need to have probably some idea of who these people are that are benefiting, because everybody and their cousin is going to come out and want to take a medicine for primary progressive, and why not? There's never been a therapy for them. I completely understand. But at the other side, we have to understand which patients are likely to benefit, because there's a risk, right? And I already told you what that was. So this was a little bit slower. This is another endpoint. This is that walk we make you do, the 8-meter walk, the 25 feet. You know, there's 2 lines on the walkway. Go, and try not to fall all over yourself and hit the walls, and you can't stop. And that's the 25-foot walk. Hey, that's the friendly one. You know, the pace, that's the one that nobody likes doing. That's the, you know, the math test. Okay. We also looked at the MRI to back us up, and the backup on the MRI was that the placebo patients slowly got more lesions compared to the group that was on the Ocrelizumab, and those probably, there's been a reduction here, and those are probably the ones who had the active lesions at the baseline, 25%, right? And then we could look at brain volume loss, which goes with age, and the placebo group is losing brain, minus 1%, but you can see there's a slight difference here, and it was enough that the computer can tell us that that's statistically significant. So everything's falling in line here for this small group of patients that experienced a 24% slowing in disease progression. It is something. It's breaking the ice. We have never broke the ice in a primary progressive trial before. It's telling us that we can get a trial done. It taught us on how to do a trial effectively. And now as we go forward with new trials, we can use this as a model. It's very important. And maybe we'll do better than 24% if we find something even better. But it encourages us to continue to do these types of trials. The adverse event profile is very similar. The differences here are bigger because there's no active arm here. So there are some side effects with interferon, but of course with placebo you're not going to get much in the way of side effects. Most of the side effects that we've been able to document with this drug are the infusion reactions. We are giving you a little bit of mouse, you know, and so your body says, hey, what's a mouse doing here? And might reject it. And so we give a little steroid to cover that, and so that's the infusion reaction that goes on. But the concern still, again, are these malignancies that keep popping up, and what do we do about them? And is it a real signal? And if the drug gets out there and people start using it, are we going to see more of that? The other problem with this drug is that because it is an immunosuppressant, it does take away our immune system's ability to react to the environment infection. Infections are going to be a problem, probably more in some people who are more prone to it. So this is where this issue of the comorbidity and what else is wrong with you comes into play. And if you have bad asthma or chest disease or other things that might predispose to infection, there might be some hesitation at your doctor grabbing hold of this drug as opposed to something that might be safer under those circumstances. So that's how we choose from amongst this. But we'll find out because, as with any new drug that hits the marketplace, the company that makes this is going to have to be very vigilant at collecting events and seeing if anything emerges as a result of taking this medication. And I've already heard of a death on the use of this drug, but completely inappropriately. A 70-odd-year-old woman, only in the United States can people get away with this stuff, who demanded probably to be treated because she's never had anything. She was in EDSS 8. You know what 8 is? Confined to wheelchair or bed with who knows probably how many comorbidities because of her, probably had a catheter and other things. And what possible gain could she have had from this? But she insisted on it. Don't know the details, but I've heard of the case. And I think this would be an inappropriate use of the medicine in someone like that because it does more harm than good. Okay, so let's move on to two other. I'm going to spend less time describing methodology, but I took the time with the Ocrelizumab trial because then I'm just going to flip through now here some data. But you now know how we collect it. You now know what some of these terms means. And so here's a drug that is making a resurgence. We've been using Cladribine for years. It's again a drug that came out of the cancer world. Its main use was to treat hairy cell leukemia. See, that I will never get that. But it's a form of cancer, and Cladribine's a unique type drug because of the way it works. But it was made in tablet form, and it came out years ago. It actually was approved in Russia and Australia, but had a hard time in North America and Europe because they only had one trial, and because of 4 completely unrelated malignancies, which when you look at the data for Ocrelizumab, kind of you go, what? Why would that hold it up? And I think there were a number of other logistics that held it up, but Cladribine now has approval in Europe, in addition to the other locations. It's under review by Health Canada. It is a tablet now form instead of an injection or infusion, so it's attractive in the sense that people can take it by themselves. And it has a little unique activity, and it's all based on this change in the molecule. The molecule is part of the building blocks for DNA. So anybody who has some basic biology knows there's 4 letters that go in your DNA, the A, T, C, and the G. Well, this is a form of the A. And so if you screw up one of these little forms, then theoretically you're going to screw up the ability of the cell to replicate and or make things that may be not so nice. So that, in fact, is how the drug works, and the reason why it's of interest is that in lymphocytes, the little white blood cells that your T and your B cells, like we were talking about, lymphocytes do not have enough of the enzyme to break that altered A down. So it accumulates and it becomes toxic to the lymphocyte. But all the other cells of the body have the enzyme. So that's how it capitalizes on being able to just uniquely hit B and T cells and leave everything else alone. You are aware that other chemotherapy is available, but other chemotherapy is not exclusive. It hits all cells of the body, and that's why you get all the terrible side effects from generalized chemotherapy. So this is like a selective cutesy drug because it seems to be one that can accumulate mainly in lymphocytes owing to the body's own natural ability to break it down and not having that enzyme in the lymphocytes. So 2 different doses were initially tested, but really the dose that's going to be used is the middle one here, which is so-called 3.5 milligrams per kilo. And it couldn't be easier. You take pills for 1 month, and then you take for about a week, and then the next month for about a week, and that's it for a year. And then you repeat it again, and that's it. And after 2 years, a number of people can go on for an additional at least 2 years, that's where the studies have been looking at, and don't need anything and are protected. The data that I showed you with the first drug, the Ocrelizumab, that's 2-year data, but nobody knows whether you need to take 3rd year, 4 year, 5 year, 6 years, like how many years do you need to take it? So I think one of the advantages here is you know that this is a 2-year therapy and then a watch period during which time you can see if anything else is needed. But most people are not on anything for those additional years. This is the placebo in the 2 arms. So you can see the placebo rate of attack is much higher than what the numbers were before, and that is just a different population in time, but a considerable reduction in the number of attacks, right? This is the time to those attacks, so how fast does it work? Within the first 3 months, you're already seeing a reduction in attack rate, that those 2 curves diverge very quickly. The bottom line here is the placebo rate of attacks, and then when we come to things like disease progression, many more patients in the placebo arm are progressing compared to the treatment arm. This is what we're trying to hope for. And then if we come to the MRI, exactly what you would expect from a drug that's going to do this. You're going to have a big suppression of new activity, a considerable progression of new white matter lesion, and then this is just combining the 2. So those numbers are not so off from what the other studies were in the OPERA-1 and OPERA-2. On MRI, it's very hard to distinguish the drugs. But the clinical effects are all pretty well the same, and this is done with a tablet. So here, if you want to think about the NEDA, forget the far right here, because that dose is not going to be used. So you can see the difference in being relapse-free between placebo and the treatment with this. So this is the progression, and then the 2 MRI sides to give a net result of a NEDA 44 versus 16. So roughly 3 to 4 times more patients completely free of any measured disease activity. Fairly significant. Downside? It's always a downside, right? It is a chemo drug, essentially. It is hampering the immune system's ability to react to infection, and so infection is a big one. And we saw a lot of herpes, zoster, shingles. So we're going to encourage people, if they want to go on this therapy, to maybe take the vaccination, even though the vaccination isn't so great. There's a new vaccine waiting to be approved by Health Canada. It's that much better. I'm waiting for that one. I haven't had mine yet, so I'm going to wait for the new one. But you might want to go on this. Otherwise, in our practice, we've actually been putting people on acyclovir, which is an antiviral drug, for the entire duration of their Cladribine therapy, just because getting shingles is not nice. And we'll just protect them from that. So that was one of the big outcomes. The other concern was the 4 malignancies, but they were 4 completely unrelated malignancies compared to the placebo arm, unlike with the other study where more of one malignancy started to show itself. That makes us concerned. And in fact, there's a huge registry now for Cladribine going back over 10 years from when the first study was being done. And I think that registry really speaks to the low incidence of malignancy and probably was the reason in which the tablets have been approved in Europe now, because the safety issue has been addressed. The third drug I'm going to tell you about, I don't even have a name brand yet, but this is called Siponimod. It is the son of the current drug called Fingolimod, right? And so this drug addresses a certain type of receptor. It's got a much shorter half-life than the current drug, so it's only about 30 hours. And it was done in a study in relapsing remitting that showed it was very effective. But because of some differences in the way it gets into the brain, it was thought maybe this will make a difference in secondary progressive MS. So the study ran, and actually the results were exposed last year around this time for the first time. And no one expected the results to be as good as they were. It was, again, an event-driven study. So the two groups here got placebo or they got Siponimod. It's a pill once a day. And then they were followed out here for as many events as needed. And then it's into extension study right now. So lots of patients, over 1,600 patients. 2-to-1 randomization means 2 times more likely to get the drug than the placebo. And at the end, there was about a 20% dropout, which is typical. The two groups do show you that this is not like a relapsing remitting study. Their patients are a little bit older, as one would be expecting here. But still, look at this. About 20% of the patients who have secondary progressive multiple sclerosis are still having active MRIs with new lesions seen at baseline. So it hasn't gone away. The inflammation hasn't gone away, and it may well be contributing. And a very similar line here for comparing the progression over time. The group that got the Siponimod is doing so a little slower than the group that got the placebo. And it was statistically significant, but the reduction was in only about a fifth of the patients, 21%. So certainly not everyone benefited. And the same story that we had in trying to keep people enthusiastic about this study, the same problem we had with the PPMS study we had with this study, because everybody's getting worse. And I have to say, well, maybe you were getting worse a little slower and tried to keep them in the study, yet some people really opted to do different things. I don't have the adverse event slide for this, but really there was nothing that it showed that we had not already seen with Fingolimod in the 2-3-year study. So nothing unusually new with this type of drug. And there's 2 or 3 drugs being developed very similar to Siponimod. One we're going to hear about that had success in the relapsing phase is going to be released next week at the big MS meeting. So that may be the next other drug for relapsing MS that's of interest. But there's like another half a dozen or so. So if I come back next year, I'm going to have all new slides for you, because hopefully we'll have better medicines. Okay, so those are the ones that are being put together by our industry partners. What about the whole thing with stem cells? And I have to tell you, this has just blossomed unbelievably. Unlike the other highly contested theoretical treatment trial that involved something to do with veins that I'd rather not talk about, which had zero credibility behind any of the research, why haven't we heard all the hype from stem cells? And the answer is because there's credible research that is being done that supports these, despite the fact that there's a lot of not so credible people all listed on here in various parts of the world who are very happy to separate you from your dollars and the promise of giving you back something in the way of a stem cell. Whether it will do anything has nothing to do with what they're offering. And so there's lots of places who can generate these cells and give them back. To what end, I don't know, but obviously to make some money. And it's not just in MS now. It's unbelievable. It's permeated down to so many different levels of all the diseases. Every disease has a stem cell answer for it. Go to any of these sites, and it doesn't matter what your problem is. They'll treat it with stem cells. No guarantees, but if you want a stem cell, they've got one for you. Now, there is a lab. I learned that there's a stem cell facility in Kingston, Ontario. No, they don't do it for MS. I think they'd be shut down immediately, but they are doing it now for some orthopedic procedures. And there's some study data that supports what they're doing. And the reason for them trying it makes sense. You're trying to avoid a major surgery. So if you can delay that surgery by maybe having stem cells encourage some repair of a disc or a knee, and the end result would be no back surgery, or let's put off that knee replacement, then it makes sense, right? But for what they're offering in terms for MS they're not offering anything. And they're creating a problem for us who are trying to do the research that actually supports this. So what is a stem cell? Well, let's do stem cell 101 a little bit here. So we all have them, right? It was a surprise to discover that stem cells are even in adults, that you don't just get them out of babies or infants or embryos, that they're stem cells, they're just sitting quietly in our body, and there is an ability to get at them. What makes them different is that they self-renew themselves, so they're always there, we'll never deplete them. And just like the cell that you once were, because everybody came from one, it has the ability to become anything. Because at one point, usually at about 7 days, you're just a big mass of all identical cells. And then magically, some decide that they're going to be the brain and the liver and the kidney, and they all start to go different directions. And what directs that is an incredible piece of knowledge that we've learned over the years. So we can now take a stem cell, put it in a dish, and say, all right, let's make some liver, okay? Or let's make some heart. And we can send them along the pathway to become anything, any organ that we want. Sounds great. Do you know where the problem lies? When you go to put it back in, they don't do what they're supposed to do. So we just made this whole liver, and you stick it in, and it doesn't behave like a liver. Why not? And one of the first thoughts of these stem cells was that we were going to cure diabetes. And there was a group out in Alberta who made the insulin cells, because we know that that's the problem with diabetes, is that you lack the insulin-making cells. So they made them, and then they shot them right into the pancreas, where the cells should be, and they sat there very happily. But they didn't release insulin like they were supposed to. They weren't communicating with the rest of the body. So it's a huge hurdle now, because we've got the ability to do it all in the Petri dish. But when we put it back in the body, we've got to figure out how to get the body to say, hey, look, we're going to replace this with these guys. So can you guys be friends and help them along? And it's not happening so quickly. And a lot of the signals that allow us to incorporate an organ system that's been grown ex vivo out of the body and then try to put it back in so that it all works, this is a big hurdle now. But I think it's amazing that we can actually grow these things. So as the cells differentiate, and that's the word we use to evolve, so as they go from just nothing, cell that can do everything, that's a pluripotential stem cell. It could do anything you want. It could be a liver or a brain cell or whatever. And as it starts to differentiate, it starts to change the way in which it looks, and they lose the ability to become everything. It's amazing now that you could actually take a swipe of cells from just inside your cheek, put it onto a Petri dish, hit it with a bunch of factors, and it sends it back to become that cell. So we can send them backwards in evolution now. And then, having sent them backwards, redirect them so that your cheek cell could now become a heart cell if we wanted it to, in a petri dish. Big difference, isn't it? So there are 4 types of neural stem cells. As we're talking about the brain, we want to talk about how we can fix the brain. We can get them from various sources. We've known about the embryonic source for a long time because there's lots of stem cells in a growing embryo. The iPSCs, the induced pluripotential stem cells, are the example of taking a cheek cell, putting it in a dish, and hitting it with some factors and sending it backwards. That's wonderful for study purposes, for research, but as you can imagine, sending cells backwards in time using transcription factors, one of which is what's called an oncogene. Anyone know what an oncogene is? Onco means cancer. So we've discovered a number of genes that cause cancer. Well, sometimes we can use these genes to our benefit. In this case, the gene sends the cell backwards, but once a cell's been transformed using an oncogene, is it safe? Nobody knows, right? Then we can derive them from adult brain. There are ways of deriving neural stem cells from adults and growing them. And then finally, we can develop them from a cell called the mesenchymal stem cell, which I'll talk a little bit about, all right? So embryonic stem cells, they're pluripotential. You take them from growing embryos. They have the ability of self-renewal. We know that. They have the ability of being pluripotential. They can grow into anything, right? And if you take them from an early developing embryo, you've got really a good pluripotential stem cell problem. But, and here's the big one, they're not from you. They're from embryos. And if the embryo, even your own embryo, even if it's your own child, is only sharing half your DNA. So if you were to grow these cells and then put them into not the same person, but somebody else, you're going to reject them. Or it will reject you, or some combination of the two. So using embryonic stem cells sounds great, but you have this problem with the potential for rejection, just like you would any type of transplant. And so it's wonderful to think that we can do this, but the reality is we can't, and there's lots of ethical issues here that surround the use of embryonic stem cells that not everybody agrees on, and so that's not really moved forward very quickly. All right? The induced pluripotential stem cells, I told you we can transform them using these 4 factors. One of them is an oncogene. The person who discovered this, the Japanese immunologist and geneticist, won the Nobel Prize for being able to show that you can take an adult cell that you could just even scrape out of your mouth and send it along this pathway where then it could form any of the organs of the 3 major cell layers that are seen in the first development of an embryo, the so-called endo-ecto and mesoderm, the ectoderm being the one we like because that gives the brain cells. And you can make anything you want from these induced pluripotential stem cells. Right now, great source for research in our laboratories, but, well, we're not quite there yet, but who knows, maybe someday we will be able to come in and just order whatever you want from the Stem Cell Depot. Like Home Depot, Stem Cell Depot, right? Okay. Okay. Neural stem cells. We can get these neural stem cells. They're still sitting around the ventricles in our brains. You can pull them out. They're very evident in around the nose part of the brain. That's where there's a group out in Saskatchewan that still does a lot of work on these precursor cells they get from animals just from where the nose is. You can send them along a pathway and they can become any of the 3 major cells of the brain. The one we're interested in is, of course, this one, because the middle one, the oligodendrocyte, is the one that makes the myelin. But the neurons and astrocytes, you can generate them all. But just like the other problem I was explaining to you, you can grow beautiful numbers of these cells. And then when you put them back in the brain, what are they going to do? And one of the first hopes along the line of these transplanted cells was in the disease Parkinson's disease, because we know exactly the cell that makes dopamine. We can grow them, and people, the surgeons, have put them right where you want them, in the substantia nigra in the brain. And they sit there. And they don't do anything. And they don't communicate. And then they did a sham experiment where they stuck the needle right in there but didn't put anything, and the patients got better. So it wasn't the cells that were curing it. And this is the issue. When you grow these cells and then you put them back in, they have to be able to do something. And they're not doing it. So that gets us to the mesenchymal stem cell. So these cells are not quite really pluripotential stem cells because they actually are part of the scaffolding of the marrow. But you can get them anywhere in the body. You can pull them out of teeth. And there's a lab I discovered. I had a call from a colleague of mine down in St. Louis. She didn't know what to do with her patient who had just gone to a stem cell facility in Kentucky, who sucked some fat out of the belly and processed the cells, and the next day gave them an injection of mesenchymal stem cells into their back through a lumbar puncture needle. Oh, no, they're doing this. You could go. $5,000 US. I said, really? The next day? When I tell you how we process mesenchymal stem cells, you'll understand why it was only $5,000. They probably managed to get a few cells out of there. But you can get them out of anywhere because every organ actually has this reserve. And I'm sure they're in the brain. It's not very accessible to take a piece of brain out and grow your stem cells. But it's a lot easier to get them from places like your bone marrow, which is very accessible. So they also can renew. They express certain markers, so it's easy to collect them. And we can force them along the line to differentiate, although most of the time we're not expecting them to do that. But they have some other very unique properties. You can see here they can differentiate into all three layers, just like the embryonic cells. And my colleague, Antonio Uccelli, and I have launched this international mesenchymal stem cell transplant study, which I'll tell you about shortly, and in the hope of being able to show that these cells can actually do something, but I'll come to it in a moment. So there's a number of people interested in giving stem cells for every condition, but MS in particular. Why? Because it's incurable, like many of our diseases that we have today, and a lot of people suffer without medication. So when they are in that particular circumstance, they're willing to do anything for anything. And so that being in mind, there are many places in the world that will accept cash for stem cells. There's lots of these in places where they shouldn't be doing them, but they can do them because of maybe some lack of normal ethics, like the United States now with their leader. No, I'm not going to go there. Okay. But certainly in Mexico, Central America, India, China, Bulgaria, all these places will advertise stem cells for multiple sclerosis and readily part you from your cash. We are doing stem cells for two types of patients right now. One is in a study mode, and that's where we're looking at mesenchymal stem cells as the potential for repair. That is not yet proven. But we also use stem cells to help us deal with aggressive MS, aggressive inflammatory forms of MS, and I'll tell you about that in a moment. So there's two types, and I've worked with the MS Society to ensure that this was on their website, but it doesn't matter how many times we tell the story, everybody thinks all stem cells are the same. And when they call us up and say, we'd like to be part of your stem cell program, I say, which one? And they go, huh? So there are two completely different, they're night and day from each other. And the first program involves bone marrow transplants. Now, bone marrow transplant is a big thing. We need to use, first and foremost, drugs, very chemotoxic drugs, to completely eliminate your old immune system. It's gone. In fact, not only is it gone, but your entire blood system goes with it. And if you stopped there, nobody would survive. So what we have to do is regrow the system. So how do we regrow it? Before we eliminate it, we derive from that individual, the same individual, their bone marrow stem cells, and we freeze them. And then we condition it, we remove the immune system, and then when they're practically near death, because we have to wait till all the chemo is gone and all the cells are on their way out, we put in the stem cells, and the stem cells repopulate the bone marrow, and then under the encouragement of some specialized drugs, regrow a brand new immune system. That is not a small procedure, okay? That is very different than the other study that we're doing, where we simply take the bone marrow, the same bone marrow that we would get the stem cells to grow a brand new immune system, so that's probably the only similarity between these. But instead, we use a specialized growth facility to grow, in particular, a purified group of mesenchymal stem cells. And when we've got them fully grown, we can then give it to patients. And they don't need to take chemotherapy. There's nothing else that they need. They just get the stem cells. So very different programs, and obviously a very different focus for each of these programs. So we'll talk about the first one, which is bone marrow transplants. So why did we do this? And as the little mouse is indicating here, it's not something that we're going to reach for readily, but in patients who have made very clear that they are not responsive or poorly responsive to the kinds of medications, some of which I showed you earlier. We have a whole list of drugs that all work by different mechanisms to try to control the disease. And if we are assured fairly early, you can tell the individuals who are not responding well enough to these drugs, then we push them along with the possibility that they could do this bone marrow transplant. Keeping in mind, when you do this, and if it's a young woman in her 20s, she's going to be sterile. I mean, you're really giving up your any potential of motherhood from your, well, I shouldn't say that, but you're rendered sterile. There are things you can do, like bank your eggs beforehand. We've had some patients do that, but that's an expensive thing to do. In Quebec, they actually pay for that. In Ontario, they don't. Maybe somebody here has the ear of our premier. They can maybe twist the arm that some things like that should be done. There's always a lifetime risk of cancer because of the drugs that we use to remove the old immune system. So it's a big risk. But sometimes if the disease is very clearly bad, it's worth the risk. And we've had, having said this thing about sterility, we've had now 3 births that I know of to patients who have had this transplant. Because 2 out of the 3 cases, they banked their eggs, and the 3rd case got an egg from her sister, husband's sperm. Drugs can ready the uterus, and she delivered a normal child. So it can be done today. And the whole idea here is that if we don't know the defect, and if there's, I don't know, let's say there's 250 people in this room, if you all had MS, I can tell you there's 250 forms of MS. And no 2 people have the same disease, right? So I don't know what the problem lies in each and every 250 persons. It may be a different mechanism operating in each of you, and it may be within the same individual a mechanism that changes over time. This is part of the problem why some of the drugs don't work, because if they're aimed at a certain mechanism, if that mechanism is not at play, you're not going to get the kind of benefit from it. Whereas this is acknowledging that whatever the defect is, it's not working with those medicines, but it doesn't matter because we're just going to knock the whole thing out and we're going to grow it all over again. And in the new immune system, theoretically, will not make the same mistakes that led to the disease in the first place, and will be tolerant, that's the word we use in immune terms, tolerant of the brain and not reject it anymore. So that was the theory behind it, And in fact, I think we've been able to prove that. So in order to get the stem cells, we pull them out of the bone marrow. And that stem cell that we can derive here has the full capacity, because it's not yet differentiated, it has the full capacity to become a white cell and a red cell and differentiate into the different types of white cells, so it can completely replace a normal immune system. Now, there are two types of transplants that are being done today, even bone marrow transplants. And some of the success that we've had is because we've decided not to pull light. We went heavy, and this is what's called a myeloablative. Everything's gone. Not only the developed immune system, but the ones that were always in reserve in the bone marrow, gone. We figured if there's any cell in any of these compartments that still remembers the disease and we don't get rid of it, it will come back. And in fact, that's what's happened, because the other transplants that are being done around the world are what are called lymphoablative. They're just worried about the ones that are running around the body. And in those studies, including the one that got a lot of publicity in the United States out of Chicago, they had a return of relapses within 2 years in 25% of their patients. So why go through a transplant if all you're going to do is get 2 years out of that and nothing more? Whereas when you use a fully myeloablative, it's more risky, there's no question, but it's more complete, we think. So what do we use this for? We use it for aggressive forms. The mild forms of MS can easily be taken care of with most of the medications that we have today. And it's the whole idea is to be completely eliminating the old system. So that's what we set out to do in 2001 with funding, thank you, from the Multiple Sclerosis Foundation of Canada. Without that, we would not have even been able to pursue this. And we launched the study in 3 sites, Ottawa being the leader, Montreal and Toronto behind. And we carried it out thinking that we'd be able to find such patients, something like 8 a year, and do the study. So that's what we did. We knew that we needed roughly a couple of dozen patients to be able to show the benefit. We were hoping for some people who would have been eligible, but after they were walked through what they had to go through, would have cold feet and say, maybe not. And they would be our controls. It's amazing how many people did not want to participate. Actually, most people wanted to. But we did have 3 who had cold feet. One, we lost the follow-up, unfortunately. So these patients came from all over the country. So I think this one was from British Columbia, and she decided to return home and pursue other things because of the delay in the MS Society really limited us to 2 a month because of safety issues, which were found. I think there were concerns there that we didn't want to have everybody transplanted and then start to have problems. So we would collect the safety data as we went. This is somebody who was anxious to get her done. So she left. The other one pursued and actually eventually deteriorated and went into one of our other trials. And the third patient, after having a full set of the chemo drug called mitoxantrone, which was in vogue at the time, promptly relapsed 2 or 3 times within months of stopping the chemo and changed her mind abruptly and begged us to put her into the study, which we did, and she's subsequently was one of the 24. So this was the criteria that we had. And that's not the criteria we have today, but you have to remember where we were in 2001. People were a little bit more conservative, and they really didn't want us to treat anyone who really didn't have a high chance of having a negative outcome. And based on the London, Ontario database that followed 1,000 patients for 25 years, we had some idea of what the natural history is. And if you plugged in people with these characteristics, the London, Ontario database said that they would have a 95% chance of being in a wheelchair within 10 years. So that being the case, from an ethical standpoint, and because death was one of the potential side effects, we had to quote a 1 in 20 chance of dying as a result of the procedure, because that's what was there in 2001. It was a risky procedure. And we did have a death very early on in the trial with one of the chemo drugs, which is known to cause the kind of problems that led to this person's death. But fortunately, that drug became available as an intravenous after the first 8 patients were done. And then after we had it as an intravenous, it was so much easier to control the drug level that we no longer had the problem that was associated with the drug when it was given orally, and we really couldn't control well the drug level. So this is the kind of group of patients that we went after. You can see here that many of the patients actually had already attempts at 2 or 3 different types of drugs before they went into the study. And you can see the spread of EDSS across here, where the majority of the people were actually already requiring a stick to walk. So they were at EDSS 6. But they got there very quickly. These were all patients who barely had MS for 5 years. So you can see that they were already acquiring considerable disability, and no one would argue that these people had a different form of MS that warranted something different. So we took, some people say, the worst of the lot, and we were criticized that we'll never be able to do anything for these people. Why didn't you take a milder group where you could at least show something? So we went to task with the worst odds against us to show anything. Patients sat on this machine for about 6 to 8 hours, 1 line in, 1 line out, in preparation to get their stem cells. And then something we do that none of the other sites in the United States want to do, because we have the advantage of literally being a block away from the Canadian Blood Services, where they have the ability to manipulate cells in what's called a GMP facility, which is not an easy facility to find. So it's a specially highly sterilized facility to handle things such as blood, right? Because this is basically preparing cells that they can go back into people. So they take this, and it's a big collection of blood, some of which contains the stem cells, but there's a lot of other stuff in there, including maybe some of the cells that could cause disease again. And because the cell of interest expresses a marker called CD34, we can take that antibody, remember the antibody with the Y's, a little bit of mouse? Okay, and we have that antibody, and the antibody is fixed to a little magnetic particle. Yeah, you can buy these. And, yep, we've used them for years. And so now you mix the cells with the antibody, and the antibody sticks to any cell that has CD34 on the surface of it. And then you put them into a big column, and around the collar of the column is a magnet. So as these cells pass through, anything that's got a little magnetic particle on it sticks, and everything else just goes through. And you do this several times, and eventually all the cells of interest are trapped here. All the other cells are here. We chuck that, and we then take the magnet off, and then all the cells that have been trapped come down, and you have a purified CD34 stem cell population devoid of any potentially disease-causing cell. And then we followed the patients. So this is a little bit difficult, but I'll walk you through it. Every line is a patient. So top to bottom here are 24 lines. Little triangles before the big vertical line here. All those triangles are attacks, relapses that they've had. So you can see here just this is two to 3 years before. Look at all the attacks these people are having, very active. And the little black line in here tells you when that patient hit EDSS 3. So EDSS 3, most of you who aren't even neurologists, if you saw somebody with an EDSS 3, you'd say, oh, well, that's not quite normal. Already, it's quite clear that there's a problem. And then you can see after the transplant, there aren't any little triangles. So before the transplant, we had something like 167 relapses in 24 patients for a relapse rate of 1.2, which is 3 to 4 times the rate that you see in any of the studies that I showed you earlier. So this was a very active group of patients. And afterwards, well, really the numbers, the slide's a little old. In 16 years of follow-up, we have not seen a single attack in anybody to date. When you look at the MRI, which is always the objective one, isn't it? The MRI shows some triangles here, and every one of the little triangles before the transplant represents an MRI with new activity. So very, very active scans. All the little tick marks after the transplant are when we looked with the MRI. So, but there's no triangles. So every scan that we've done in the 16 years of follow-up has not detected a single new lesion in anybody who's had this procedure. When you look at how fast things were happening before the transplant, that's how fast over years they go into 3 or 6. So you can see how aggressive these patients were over a period of only 5 years. And then this is what happened afterwards. And most of this line is being generated by the one patient, unfortunately, that died, because can't say he's progression-free. He's not there anymore. But there were some patients who, despite the fact that we shut off all attacks and we shut off all MRI activity, whatever they had acquired before the transplant kept running afterwards. And we saw it for a good couple of years, but then even they leveled off completely. So a lot of the damage that was building up prior to the transplant and kicked in whatever the scarring was necessary didn't get changed the minute you do the transplant. And we've known that for a long time, that when you intercede today, you can't change what was done, but you affect what's going to happen tomorrow. And so that gets translated down the road. And I think a perfect example of where we saw, oh, and actually this was, the dramatic thing was that there were a number of people, more than half, whose deficits just simply disappeared. And many of them recovered. Told us something we didn't know, that if you stop all inflammation and let things recover now, the new immune system came in and actually was probably capable of repairing. And some of those patients had, and you've seen the videos, I'm sure, dramatic recovery. Jennifer, who's our poster child for this, and there's several of Jennifers around, I can tell you. She's just the one who likes to talk about it. She was an EDSS 6. She was with a cane, and you would not know her from normal person if you saw her walking around today. And that was quite the surprise. So that's the potential if you can stop the disease from going on. The delay in the response, I think, is identified here by, remember that brain volume thing, the loss of brain tissue? So this is the rate of brain volume loss, this line here, in a normal, non-MS, age-matched, controlled individual, right? Because you're losing brain at different ages at different rates, right? So that would be if you didn't have MS. This gray area here is at about 0.4% per year, is typical of a non-treated MS patient. The rate of brain atrophy runs at about 0.4% a year. So this is our time period here, and you can see this is the effect of the drugs. Look what it does to the rate of brain atrophy. We know this is a toxic effect of the medication, but fortunately that's the second 6 months and this is the first year. So it's a temporary thing. Drugs can change brain volume. You all know that. Don't ever measure your brain on a Sunday morning after that Saturday night fun, because alcohol will do it readily. But fortunately, it's reversible in most situations. So that's the 1 year. And then as we go out here into 2 years and 3 years, that's where we started to see something we didn't expect. So at 2 years, our patients were still losing brain at the same rate as an untreated patient. Why? Because this probably reflects what went on here before the transplant. Now, at 2 years, one would expect that whatever was previous is done. And sure enough, by year 3, 4, and 5, the rate of brain loss is no different than the patients who don't have MS at all. And that's what we've seen going out even further. Did it have any meaning on people? It had a lot of meaning here. In the patients who had improvements here, 58% went back to work, 81% came off of long-term disability, 81% maintained their relationships with their spouse or partner, because that's a big problem, and almost 70% got their driver's license back. So that was pretty impressive. Okay, so I think we can show that a full bone marrow transplant in the right patient will stop new accumulated damage and allow and promote recovery. We know that. Oh, and I guess I failed to mention that none of these patients are on any disease-modifying drug whatsoever. So they have their transplant and that's it. They're not taking any medicines anymore for their MS. There's still lots of questions that we have. We've been, of course, loosening our criteria for patients, and I know what your questions are going to be. Who are you taking these days? They're still very much considered aggressive patients, but without those specific criteria of the EDSS. We're trying our best to try to find new concoctions of medicine that maybe aren't as toxic. We'd love to figure out who can recover and who couldn't. We clearly saw recoveries in half our patients, but some didn't recover. They just stabilized and just didn't get worse. But who's going to really benefit in terms of the recovery or questions that we're asking? How soon would you want to introduce this? Like, how many drugs would you want to fail before doing it? I get this question a lot. And I think that for the most part, in order to really know if somebody is not able to be controlled with our run-of-the-mill therapies, we need at least a year of a trial to be sure. Sometimes not even that, but we've done 2 transplants as their first treatment. But these are exceptional patients who have clearly been sitting too long in the middle of nowhere and not getting attention and only coming to attention what we think is too late. So under those circumstances, we've offered it as almost a heroic measure. And why is it once patients are into this progressive phase, why doesn't it work as well? And we don't know that. But the attempts to do bone marrow transplants in patients with purely progressive forms has not been rewarding by anyone who's done them using any techniques. There were more problems than any benefits that have ever been perceived. So unless the disease is very active and inflammatory, it's not likely to benefit from this type of transplant. I hope I've answered that question. Now, what about the other guys? I don't have a lot to tell you because the study is fully recruited now, at least in my site. We're still waiting for the guys out in Winnipeg to get their act in gear, but they're a little slower out there. That's the West. And they'll eventually bring all their patients in, but we're looking at 185 patients worldwide, and I think we're at the 160 mark. So we'll have this study fully recruited probably by the latest early spring, and we'll have the answer by this time next year. We'll have the answer as to whether this works. So this is the cell you can get from fat or you can get from the bone marrow. This is the mesenchymal stem cell. You can grow them. They look like this, so they're very spindle-like cells. It's very easy to identify them and purify them, but it takes time, okay? So it's one of 3 different potentials. The big one here is the middle one, because they themselves are anti-inflammatory, and the other one that we're really hoping to be able to exploit is their ability to repair. And so this is how you have to grow them. And it takes 2 to 3 weeks to generate the dose that we're looking for, which is 1 to 2 million per kilogram of patient. Not the overnight separated from whatever and here's an injection, okay? It takes 3 weeks in a specialized facility to grow enough cells to give a single dose. So I think if we're successful, one of the big questions I got asked at a public meeting on Monday was how quickly will this translate into the ability for most people to get cells? We don't have these facilities sitting around everywhere. There is one in Toronto. At most, our facility can handle only 2 people a month to grow the cells because they take over so much space. So unless you build a new factory out in de Havilland, you're not going to be able to generate enough of this. But that's where, if it works, that's where we're going to need some effort here to generate the kinds of facilities that will be able to make the cells. Because what makes them interesting is they're from yourself. So there's no rejection, there's no issue on that. You're growing your own mesenchymal stem cells and you're giving them cells back. And so we're part of this Canadian contingent of the big mesenchymal stem cell transplant program. It's one of a series. We're going to pool all resources. We're all growing them according to our individual countries' rules, but we're using the same cell source and we're using the same techniques. And then we're going to put them back and we're going to give them only intravenously. There's something when you give things intravenously that are different than if you try putting them directly into the organ. And I think our transplant colleagues are learning this. There's something about the way the body recognizes the stem cell and then processes it so it knows where to go. And the people who are giving it intrathecally are probably acknowledging the fact, intrathecally means into the spine. They're acknowledging the fact that they don't have very big numbers. They might as well just put the money where it needs to go. But they don't do anything. We know that. When you give cells intravenously, the first place they go, does anybody know? Your lungs. Because that's where your body pumps them to. And it turns out that your lungs are a very important immune organ. We've known it for years. Any part of the body that sees the outside is armed with a very potent immune system. Think of your tonsils and your nose and your lungs, because you're breathing the air, you're always exposed to something, right? The other place is the other tube, right? So your gut is lined with an immune system. And so anything that you do in your lung or in your gut could conceivably change the way your immune system sees and does things. That's why all the big fad on diets today for MS, although nobody's shown anything, but everyone likes to say something. So they don't have to prove anything, they just have to tell you it, right? And buy this supplement. Snake oil. Oh, no, that's old. I don't know what. But you can give all sorts of things because you don't have to prove it because it's the gut. But, smoking, we now know, is bad for you. But it's also bad for your MS, and it might be because of what the lung is doing from its immune perspective. You may be changing something. So the first place these stem cells go are the lung, and the lung has a way of somehow identifying these cells and saying, we got trouble upstairs. Forget about what's going on down this, in the legs or something, but we need you upstairs. And then these cells are now directed to go wherever the damage is. We're doing mesenchymal stem cell transplantation for septic shock because of their anti-inflammatory capacity in patients who've not been able to be treated with antibiotics. We're doing it for, there's a big program involved, we're Ottawa, Toronto, and I can't remember how many other centers, treating heart muscle that's been damaged from heart attack. So you just give them intravenously. They go through the lung, and the lung says, someone down there says, there's trouble in the heart. That's where we need you. You go there. And the cells find their way. So I think the intravenous route is really important. That's why we're only studying that. We don't care what form of MS you have. And I told you before, nobody knows the difference if you look pathologically. But because the primary outcome, we had to be able to show that these cells are active, that biologically they have an anti-inflammatory capacity, and if we can demonstrate that, then maybe we can also demonstrate the repair. But we know how to measure inflammation and the lack thereof. We don't know how to measure repair very well, and so the primary outcome is MRI, and that's why we needed patients who had active disease to go in, and we didn't care what phase of disease they were in as long as it was active. We're going to measure a whole bunch of different things to try to see if we can pick up a repair signal. These were the criteria. I'm showing them to you, but we're fully recruited. Right? Unless the MS Society can come up with some more funds, we're done. We have put in our 20 patients that we promised to put in. It costs, our cost for the growth of these cells alone is close to $20,000. Now that's nothing when you compare it to a year of disease-modifying drug, which costs about the same, but it costs 20,000 Canadian dollars. So these sites that you go to in the United States that says that they're going to give you mesenchymal stem cells for 5,000 US, what are they giving you, right? This is our cost. We're not making any money on the growth of these cells. This is what it takes to actually run a lab to do it. So we're bringing in these patients. We don't care if they have secondary progressive MS, as long as they have activity. They went in, and same true with primary progressive MS. As long as there's something we can measure, we brought them in. And we have patients in the study from across Canada, believe it or not, who are willing to move to Ottawa for the year so that they can be involved in the mesenchymal stem cell. And we're more than halfway through now. And the last patient's going to get their cells probably next week. So I hope that I've been able to, in the last while, and I've been talking for a long time, tell you about some important new advances of medications that we have today to treat, especially now progressive forms of MS. These trials are starting to give us enthusiasm to go forward with more such trials. I hope I've explained some of the cell-based therapies that we are doing here and what their magic may be for some people. With that, I will at least acknowledge a few people here. Lots of the people who got involved with us in the various forms of the bone marrow transplants or mesenchymal stem cells. I think the most important acknowledgement here is probably you and patients like you who were willing to give their bodies, more or less, to these different trials. A lot of brave people went into the bone marrow transplant study, and none of these studies would be possible without the efforts of our MS Society and Foundation of Canada, who have been able to put enough funds aside to allow this type of research to go forward. So thank you very much, and I'll take any questions I get from you after a while.
Comments, but all I can say is wow. And I think for those of us who've been around, for myself for 25 years and others, I can't describe the emotional reaction that I got listening to this presentation, only because when I started there was nothing, and now there's so much, and there's going to be some exciting things. So I thank Dr. Freedman so much for being here and for his work. I know you have a lot of questions. We have about 20 minutes. I'm going to watch the crowd very carefully. I'm asking that you keep your question to a minimum, that again, no personal particulars. And if I ask you to stop talking, it's out of love. But because I do want to make it across the room. If we don't get to your question and you have the ability to write it down, we will get an answer for you. So I'm going to start on my left. I'm going to work my way across. We're going to see how we do. So please speak into either Jessica's mic or where's Jennifer? Or Jennifer's mic. So I will make sure a mic is brought to you so the question is heard on the recording. Jessica, your first question, please. We'll go to right there, Ellen. Yep.
I can hold it.
No, we would ask Jessica to hold the mic. Thank you.
Okay. Dr. Freedman, thank you. What can we do to improve our MS brain health? And also there's an expression, if you don't use it, you lose it. Are MS patients more susceptible to losing their muscle integrity?
You faded out on the last part. More susceptible to losing?
Muscle.
There's an expression, if you don't use it, you lose it. Are MS patients more susceptible to losing muscle integrity?
Okay, and the first part was?
Brain health.
Brain health. How do you improve brain health? Because I thought that's what you were going to get at with the second part of your question. So it's actually two different questions. I don't know what brain health means. So there's lots of terminology thrown around today, but I will use this opportunity to talk a little bit about cognition. And I thought that's what you were getting at with if you don't use it, you lose it. And that is true of everything, but especially cognition. And there have been lots of attempts now to prove that exercising your brain can improve your reserve. And what's the reserve? That's the reserve that you go to when either aging or a disease causes you to lose brain. Then you're going to start to, just like when you use up your tank of gas, if you didn't have a reserve, you wouldn't get to your final destination. You can imagine that if you've built your cognitive reserve, then as the disease starts to cause brain atrophy and brain volume loss, you still have the capacity to do things. And there's a lot of programs now that are being implemented. One we're using in Ottawa is called CogSmart. But there are so many programs like this that attempt to get you to exercise, doing things on a regular basis. Because MS, well, a lot of people have had to stop their work, and therefore they don't think as much like they were using it before. So it's really important to do that. Are you more prone to losing muscle? You're no more prone than anybody who isn't using their limbs, be it even it's a broken leg or whatever the cause may be. If there's no exercise involved, then there's no stimulation of the muscle. And if you're not stimulating the muscle, then you're not going to maintain the muscle size. But having MS makes you no more prone to losing it unless you're literally not using the limb for various reasons.
Okay, thank you. First up front, and then we're going to go back into the middle. Yep.
Thank you very much for your great presentation. I have a question regarding the mesenchymal stem cell research that you mentioned. I actually have two questions. Have you ever considered using the allogenic MSCs instead of autologous?
Yes.
And my question number two is that, based on that, the broad range of age inclusion in your research, like ages between 18 and 50, and using same person stem cells make it a little bit less quality when person ages. So basically, the quality of bioactive production in older people are less than younger people. So the treatment then, as a result, may have a more positive effect on a 20-year-old than a 50-year-old.
Well, so both of those are excellent questions.
So the first, can you just repeat what she meant?
So the first question is, in the mesenchymal stem cells, we're using the person's own. What about using some general source, like not of yourself? Well, in fact, we've done a study a few years ago with a company that makes these cells from placenta. And you can get lots of cells out of a placenta. But again, they're not of yourself. Turns out the mesenchymal stem cells are so primordial, so early in their differentiation, that they don't even express the markers of self. So they wouldn't be rejected. But so these were pooled cells that people grew out of placenta. And although it was safe, there was absolutely no signal that was associated with those. Now, it may well be that we could sort that out and then have a ready source for mesenchymal stem cells that could be used across a number of patients. And that's still being explored. But we figured the best chance is still from the person's own cells. Now, there have been studies that say there's nothing wrong with MS patients' mesenchymal stem cells. There's nothing that says that an MS patient can't make one any differently than a patient who doesn't have MS. And yes, there is an age relation in terms of your ability to get them, but keep in mind, we're propagating them in a lab. So all you need is a few seeds, and then you get millions of cells when you start to grow. And we have not seen any difference in our growth potential taking them from a younger or older patient within the range that we've done, and that's worldwide.
Yeah, and how about the activity of producing material?
So the activity of the cells, at least in vitro, in the Petri dish, are no different. whether you get them from an older or a younger patient. We're not talking 70, 80. We're talking, you know, in a younger group. And the things that we measured that says that they might be useful are no different between MS and non-MS. And there's some groups who are differentiating that, but it depends where they're growing the cells from. I mean, the cells that you grow out of fat cells versus bone marrow cells versus placental cells, and there's numerous other sources. No one's really done a good comparison amongst them. So that's why for our study, we're all taking them from bone marrow, we're growing them the same way, so the result will be hopefully a uniform result.
Okay. Thank you for your question. We have one on this side, and I'm working my way across.
What we noticed is that all the tests, of course, have an age limit, which is 50, 55. What's for older patients? What do you have? Is there stem cell studies that are being done also for the older? What kind of hope can they have?
So older patients.
Yeah, well, we're doing a study now where the top range is 70. So it has to do, people don't just randomly cut you off at a certain age. It's, you know, you have to have a cutoff because the authorities won't allow you to do a study if you don't. So it's not like we're being, you know, nasty, but we're held to those age ranges because that's what the authorities force us to do. The top end of the range has to do with the therapy that you're offering. And there are, let's face it, some of the drugs have more toxicity in an older patient group that may be more prone to things than a younger patient group. So the study that's ongoing now that's still recruiting, as far as I know, is the biotin study. And the age is well up into 65 or 70, I think they're taking patients, because there's little chance that the drug will cause any problems. But that's the reason for it. Just because the studies limit themselves to 18 to 50 doesn't mean that if you're 51, you wouldn't benefit from that drug. It's the study that limited. Now, once the drug is available, it's up to us whether we think it's of benefit to an older patient to try it.
Sorry, our older patients.
So you're asking a general question. What type of stem cell? Are older patients likely to benefit from stem cell? What kind of stem cell? Okay, so not the bone marrow transplant. It's unlikely, right? But could they benefit from mesenchymal stem cell? We don't know. We don't know if anybody can benefit from mesenchymal stem cell until the studies prove to us that they can work. All I can tell you is the longer you've had a problem, if it's been the same problem that's been there for many, many years, the likelihood is that problem represents a scarred nervous system. And just like a scar on your skin, it's not going to go away. And so if you're looking at repairing a scar, it's much less likely to do something than if somebody has something fresh, where it may be still in a situation where repair is possible. This is a big problem for us, and I can use your question to help maybe answer a few other questions that might come up, is how do you know who has repairable disease? And I don't know, right? If somebody isn't walking and it's due to MS, is it because the wires are all stripped and not conducting, and all I have to do is rewrap them and they'll work again? Or is it because the wires are cut? And we have no way of differentiating that yet, at least through our tools or technology. And so we just have to treat everybody, and it's going to be clear that the people who had cut wires are not going to benefit, but those who had the strip wires will. But it would be much better if we could identify the two groups and say, well, you know, they don't have repairable disease, they do. So we don't have to needlessly treat a lot of people. And I think that's what you're seeing in those curves for the two progressive studies, where everybody's getting worse, but some people are getting worse a little bit slower. Maybe they're the ones who still have repairable lesions.
Thank you. So we have one more question here, then I'm going to go to Jennifer and work our way across a little bit in fairness. So go ahead.
Okay, thank you very much for all that you do with all your research and studies. from my understanding all the years, MS is still multifactorial as far as causes, and we don't know everything, otherwise we'd have some more answers. The genetic component, is that still something? And if you're doing transplants and we're getting rid of the immune system and replacing it, what about the person's genetic predisposition possibly to developing these kind of autoimmune problems? And then so where do we see that fitting into what you're doing?
You sound like one of my critics in 2000. No, it's a great question. And that's exactly what the critics were saying to us. If this is a genetically driven disease and all you do is replace the immune system, isn't it just going to come back again? And we said, well, we don't know. But guess what? We're 16 years out. If it was genetically driven, why didn't it come back? So all we can tell you is the genes certainly are there that give us some kind of tendency to develop the disease, but it's not enough. And we knew that 30 years ago when we did the genetic study here in Canada with the twins. Identical twins, same DNA. What's the chance if one gets it that the other one's going to get it? If it was genes, what would it be? 100%. What was it? At best, 30%. Then they even looked at people who were genetically the same and reared in different houses and all those studies that were actually funded by the MS Society of Canada. And we discovered a lot about the genes. Only to say that there's genes that confer susceptibility, but even people who have those don't develop the MS. It's something else, and it's the way the immune system works. And I know we're running out of time, but I'll use this moment to give you an idea of how this works, right? Our immune system gives us the tools to fight the infection. Let's say there's a whole table full of different tools. And what makes the two genetically identical patients interesting is that they have the same table of tools. In comes the virus, and now the two twins decide what they're going to do. Do I throw a knife at it? Do I shoot it? Do I fling a frisbee at it? What am I going to do? Whatever they do, they're going to choose different ways. So even given the same genes, which give you the table full of tools, how individual chooses to use those is different. And that may be how the disease develops differently in two individuals. I hope that little analogy helps you. Okay?
Thank you. Jennifer in the middle there.
Thank you very much for doing a little bit of a deep dive. That was really helpful. Can you speak just for a moment about biotin and what the hopes or thoughts might be about biotin that would cause you or cause it to be put up for study?
Well, it's an interesting idea that was raised by a French neurologist scientist who went back to the basic grade 7 biology of the Krebs cycle, which is that thing that we all had to memorize with all the little sugars and things. Yeah, everybody's nodding, right? You forgot it after that. So it actually works in all the mitochondria, which are the industries of every cell that makes energy. And so it looks like an observation that Bruce Trapp made some time ago is that if you take a wire of the central nervous system and take away the insulation, so now you've got a bare wire, it may or may not conduct, especially dependent on heat, right? As soon as you raise the temperature, it doesn't conduct well. But what it does to enhance the ability of a signal to get through is it sends all the mitochondria to that area. So now they're all lining this area. The places that are already wrapped, they're okay. But you've got this wire now that needs a lot of energy to send a circuit through, right? And otherwise it doesn't complete the circuit, you don't get a signal. So it's a supply and demand thing. If you've got a bare wire, you've got all these mitochondria who are trying to generate enough energy to send the signal through. If they run out of the supply, then the signal will falter. And what they noticed was that if you take high doses of biotin, vitamin B7 is one of the catalysts that's involved in that cycle in the mitochondria that generates the energy. So it's literally, it's like, you know, putting a little nitro in your tank, right? It gives you a little booster for that energy producing mitochondria to be able to sustain the the signal through the wire. Your inability to sustain the signal eventually sends a message back to the neuron, which is sending the signal, saying, you know what, you're not getting any message here, you might as well go on holiday. And if that happens, the wire breaks, and that's the end of the story, right? So if you can sustain the signal through, there's a chance that that will even repair. So what happened was that they took a bunch of people who had progressive disease, and they gave it biotin, and you can see that some people have cut wires, they're not going to benefit. But those that had the wires that were running into a supply-demand problem and suddenly were given a boost of energy, they're able to maintain the signal, and they actually got up and started walking a bit. 12 to 13% in the phase 2 study. But it's encouraging to think that if this works, we can get at the other question that I answered here, is trying to figure out who's got repairable disease. We might just, give people biotin and see if there's anything objective, and then that would be the focus of a patient that would go on and maybe undergo a reparative strategy. But it's the first drug or treatment that actually wasn't slowing progression. It was actually looking for improvements. And so that's what makes it a very intriguing study, to see if we can get that data to support it. I hope that answers that.
So I see a lot of hands on this side, but again, I'm asking that if you need to, I'll ask you to write down your question, but we're going to get as many as we can. So over there, and then we've got up front, I want this, because he's been waiting for a bit. So go ahead, Jennifer.
Hi, Dr. Freedman. I just want to say, wonderful talk. You've answered even more than all of my questions. But I think what it boils down to now is you're saying that you need money. If you, Lisa McCoy from the Assisted Development Devices Program and the MS Society, is willing to give me 15 minutes, I'll show you how to get unlimited funds. I'm willing to make a fool of myself if you'll give me 15 minutes, if you'll do that. Because I can get you unlimited funds, and then we can cure this disease, and we can all go out of here and do something else.
Thank you very much, and
Hire
I will forward your email on. Okay, so we had one just beside that table. Oh, sorry, yes, in the black there. Then this gentleman, and then we'll see.
Hi, Dr. Freedman. Thank you so much for your presentation. It was really super thorough and really informative. I just wanted to ask, what is the thinking behind the differentiation between primary progressive and secondary progressive in terms of the evolution of treatments? Like, because you said today that, okay, we're seeing results for relapsing remitting, but not so much for primary progressive. And I remember when I got diagnosed, like about 20 years ago, that there was a thinking that they were maybe different diseases. Has that evolved at all?
As I alluded to earlier, no one can tell the difference pathologically or radiologically amongst these things that we described as neurologists. We're to blame, because when we don't know something, we just say, we don't know what caused it, but here's kind of the pattern. We were trying to describe a pattern, thinking that a pattern of disease matches something that we're eventually going to find out. What we eventually found out is that progressive disease all looks the same. And even if you say they're primary progressive, a quarter of them will be having attacks and relapses just like the secondary progressive. The only difference is you can't be secondary progressive if you didn't have relapsing first. But there's no other difference. So it's terminology. It's not disease. And I think that if we find something for primary progressive, of course I would think it would be effective for secondary progressive. How the authorities deal with this is another story, and the payers and everything. We'll work our way around that. Just hope the wall doesn't have ears, but progressive disease is progressive disease to me, and it is to you, and it's to everyone else who has it, and I can assure you that SPPP, the differentiation between those two is meaningless.
Thank you. I'm going to let Jessica go first, then the woman in blue, and then we'll just see how we get further. All right, and then we need to finish up. Okay. It's okay.
I must say I'm impressed, with this presentation and with work you do. The question I have is, what's the difference between hematopoietic and the
Mesenchymal.
Mesenchymal. That's one question.
I thought I answered that.
Yeah, you did, but maybe it was so many, so much information that I just...
Okay, we'll come back to it. What's your
Yeah.
second question?
The second question is, like, I believe that, like us, many other people are under tremendous pressure to go to Mexico, those other places, pushed by those...
Pushed by those places.
No, pushed by...
By social media.
Our son or whoever is sick.
You should have told your son to come here, and I would have told him differently.
Yeah. What I wanted to ask, my understanding was from your presentation that next year, this time, we may have some clearer picture about what can be done to repair.
Yes, if we'll find out whether or not mesenchymal stem cells, which we take out and grow and put back without any chemotherapy, are able to generate some repair.
Yeah.
That's what we're hoping to be able to show you in a year. If we didn't succeed, it may be because we're not looking in the right place or using the right tools, but we'll find out something by this time next year.
What I wanted to say is that the other places are looking for $50,000 for fake treatment.
Yeah,
And,
that's a bargain.
Next year, like, you're underfunded, so. And then you need like a fund to
So you think
to
I should
last.
start offering it for
No,
$50,000?
I would gladly pay
idea?
you $50,000.
Gladly. Thank you for...
I have something that they don't have.
No, what
I
I'm
have
saying,
ethics, and I won't do that for money, okay?
No, I would gladly pay to your lab $50,000 to continue your research because I'm really, really impressed.
I'll just
So-
introduce you to the people at this
That's right.
table over here, and you can...
So if I could ask you, your first question, though, related to the differences, we do have our research table in the exhibit hall. You can get some information there, and definitely you can contact the MS Society regarding how you can support. I want to only take two more questions.
website.
I do ask that, so we have the woman in blue, and then we'll go from there. So woman in blue.
I think you might have answered my question just with your last statement.
Okay.
But it was, why wouldn't a person choose this mesenchymal therapy over bone marrow? Because bone marrow sounds so invasive, and the mesenchymal, or whatever it is, sounds a lot nicer.
Well, I really try to distinguish the two for you during the talk, and they're night and day. You know, bone marrow transplant involves chemotherapy and elimination and everything, and this is totally something else.
Okay,
It's
we're almost
looking at
finished.
repair.
Okay.
Why you don't choose? No. If you want to choose, you can go to Moscow or the clinic in Mexico. That's your choice. Okay, you can go and pay whatever you want for these procedures. I think that when we're in a better position to be able to advise and help you to choose amongst these, and this is something that you'd have a discussion with your neurologist.
Thank you. And I just want to remind you, we are having another neurologist speak this afternoon, though it is on pain and MS. He is more than able to answer many of these questions. So I did miss, okay. We're standing between you and your lunch, so I'm going to give you, what's your question quickly? I'll repeat it, yep.
Very painful disease, and a lot of people...
Why don't you save that
So
question
MS
for Dr.
and pain
Robinson?
is going to be discussed this afternoon with Dr. Tania Bruno and Dr. Robinson, pain and MS. Wait for that. And this gentleman up at the front, I'll repeat your question, unless Jessica's there. Oh, sorry.
All the studies you've shown talk about EDSS, and which is, I guess, basically gait and the 20-foot walk. Can you talk to the cognitive impact, which for a lot of patients is the primary thing, but it's obviously not as easy to measure as walking 20 feet.
You just answered your question. So the answer is there is no good consistent way of measuring cognition. We do it using some tests like the PASAT, and if anybody's done that, they sometimes walk away from our studies because they hate it so much. There's no quick answer. So the proper, even the cognitive batteries that have been useful and proven and validated take 15 to 20 minutes. Can you imagine a study with 1,600 people all undergoing 1 million different procedures and then having to spend extra time now trying to test their cognition? And the other thing is it's very insensitive to change in a short-term period. So although we've accumulated a lot of the data for every one of these studies, but being able to show that a medication actually changes cognition in a short period of a year or two is almost impossible to find using the measures we have. It's not that we're belittling it or feel that it's less important than the ability to walk. If anything, it's the opposite. And it frustrates us that we're not able to get better tools to assess it. We were kind of getting at it with the brain atrophy thing, but you know, so many things contribute to brain atrophy. But the best correlate is actually cognitive functioning. So we're kind of getting at it. We feel it's very important, and I agree with you, but it's just not been possible to test it in a methodical way.
I am going to have to end on this note because we do have other speakers coming that some questions can be answered there. And I do want to thank Dr. Freedman very much for coming today.
Thank you.